You are listening to Pharmacy, IT, and Me, your Informatics Pharmacist podcast. Welcome to another episode of Pharmacy, IT, and Me, and as with every episode, we start off this one stating that the intended audience is everybody. So today we'll actually be speaking to our special guest and friend of mine, Dr. Emmanuel Akinwole, on what his role is in the pharmacy, technology, and informatics world. So thank you so much for taking some time to be on the podcast. How are you doing?
I'm doing well, Tony. Thank you.
Yeah, it's been a while, right, since I last saw you.
Yeah, it's been a little bit. It's great to kind of connect with you again.
So I guess for our listeners, can you tell them a little bit more about yourself?
Sure. So my name is Emmanuel Akinwole. I'm an informatics pharmacist at Providence St. Joseph's. I actually support two of their facilities, Little Company of Mary Torrance and Little Company of Mary San Pedro. So I actually got into pharmacy because of my aunt, who became a pharmacist when I was in middle school. And so that kind of started me down the pharmacy track. And then I went to USC undergrad and USC pharmacy school. And afterwards, I applied to and started a 2-year administrative residency at the University of Wisconsin Hospital and Clinics. And so I was in this 2-year residency, and it was during that time that I got exposed to informatics and sort of decided to go that route instead. Epic is actually based in Wisconsin. So I got certified in Epic Willow, which is Epic's module for pharmacy. Came back to California and got into pharmacy informatics. So that's kind of how I got into the field.
So you said that you got exposed to the informatics side in your residency. So what made you actually actively decide to pursue that route?
I think for me, I love working with data. I love the way technology can be leveraged to improve healthcare delivery, to improve the medication use process. I just got really fascinated with just all the things that could be done, all the ways that we could analyze data to improve our operations, to improve our clinical care. And yeah, just and the way that interface with all of our systems, all the technology in terms of automated dispensing cabinets. We had a robot there too. So it just got me really interested in that whole process. And it's just something that I saw myself doing.
Awesome. So in your current role, what are your typical responsibilities? Do you have like a day-to-day thing that you do, or does it change a lot?
I mean, it changes from day to day in terms of what I get asked to do. I mean, there's a maintenance piece, which is just, maintaining the med list, making sure those are accurate, helping with making sure that medications can interface with Pyxis machines and troubleshooting those kinds of day-to-day issues. So that's a part of my day and the things that I kind of work on. The other big part of it is just optimization of our system. So when our users have requests related to, safety or just something maybe working better, a particular workflow in the system, then they kind of come to me to initially sort of triage those issues and see, can we take care of them locally, or do we need to do something at the system level? And so because our hospitals are a part of a larger system and we all share the same build, so Providence St. Joseph's is right now, I think 50 hospitals plus. And so, whenever we're going to make a decision about changing something in the system that's going to affect everyone, that has to go through governance groups and committees. And so I'm part of the process to shepherd those and to sort of have the discussions and talk through the discernment and the build and what that would do to our system and get all the approvals necessary. So that's also a big part of what I do at the system level to make changes in the system. And other than that, I just kind of do a lot of just workflow support for my end users as well.
Okay, that sounds good. So you said that you oversee kind of the build for 2 hospitals, right? Is it difficult to, I guess, try to get them in sync, or do they have their own separate builds that you are supposed to maintain separately? How does that work?
So some of the medication lists are local. In fact, like the way the build is set up, whatever they stock in their pharmacy, whatever they want their providers to see, all that is managed locally. I mean, because we share the build across the system, right? There is a lot of system build and system decisions that affects both hospitals. Additionally, the director of pharmacy for Torrance, about maybe like a year and a half ago now, became the director of pharmacy over both. So they're starting to behave more and more like they have the same type of operations and they're trying to align more and more the things that they're doing. So So that's something that has become easier when they have the same leadership. They have the same leadership, operationally. So they have kind of similar goals. And so it makes it easier to kind of to support them both when they want changes and things like that.
So what aspect do you see at your institution that has shown to be the greatest support for what you do in your role? Like who has supported you, or maybe what kind of governance has supported you?
So in terms of kind of the most supportive structure in terms of what I do at our facilities, I think the way that we've set up our analyst build team and our informatics team is really good. We have pharmacy informaticists embedded in each of the ministries. And so, like, I'm responsible for 2. Typically, a pharmacy informaticist will be responsible for anywhere between 2 and actually 7 hospitals. But some of the hospitals in Montana are small critical access hospitals, so they're much smaller. And so we interface with the pharmacy end users and with other local end users for their needs. And so we kind of do the initial groundwork to understand what they would like, to kind of clarify their asks. And we do reports and things for them. So we kind of do that at the local level. And then we have a team that meets up virtually multiple times a week to kind of discuss the issues that come up. And so to get advice from other informaticists if they're having similar issues locally, or kind of do initial vetting for system changes and optimization requests. And then so we kind of can do that in our own team. And then so the analyst build team is really freed up from having to interface with end users really at all. And so they're free to just build. And so once we've vetted our requests, once we've kind of translated their requests, we go to that team and we can translate what we would like to build or what would be good solutions. So, I mean, we actually work really well in terms of us as an informatics team being able to vet requests together, and also working with the analyst team, shielding them from, unvetted requests, unfiltered requests. And so it works really well.
Wow, that's a really good structure. I don't see that often. Like in the places that I've worked, it's kind of been like the informatics team and analyst team are kind of one team. So the way that you guys have it, it's actually a good way of like delineating, only sending the vetted request to the analyst, which makes a lot of sense.
Yeah, saves them a lot of time.
Yeah. So are there any interesting projects that you'd like to talk about, or that if you can talk about?
There are some interesting projects that we've kind of worked on or are working on. At our location in Torrance, they started an ambulatory clinic on site. And so the director of pharmacy is really interested in getting pharmacists out into the ambulatory space, kind of knowing that we're kind of trying to get out of this, focus on acute care and more into population health and preventative care. And so we kind of opened up that clinic really within the past year. It's been maybe like a year and a half now. And there's been tremendous growth in that clinic. And now we're trying to move into telehealth. So we're trying to initiate virtual pharmacy visits so that patients can see the pharmacist from home. And really that just kind of speaks to that recognition that, patients already have, especially the patients that we need to see who have complex drug regimens and multiple providers and specialty providers that, they already have a really large burden in terms of seeing healthcare practitioners. So if we can help them see us from home, we can kind of look at their meds from home, they can just show us on video what they have. It's really much more convenient for the patient. So we're kind of working on getting that project going. That's one of the innovative things that we're doing now. And then I think in terms of hospital operations, one of the things that I've been hoping we can do is really kind of look at some of the default settings we have in our system for medication turnaround time. So depending on the system, they have a default setting that gets put on medications when they're ordered in terms of, what time they're due. Right? Our system right now, it's 30 minutes. And so it's the pharmacist's responsibility to push it out to maybe an hour, 2 hours so that they can get the med up. But I feel like that default time, it would be nice if it just defaulted to 2 hours out. Most of the meds that we give in the hospital it's not clinically necessary that the patient gets them, stat or within an hour, right? They're not going to have a huge acute benefit to the patient. And so it seems like a lot of the times the entire hospital is kind of running on this wheel of, got to get these meds out when, again, it wouldn't matter if the patient got it, now or later for a lot of meds. Now, there are some meds, antibiotics and things like that, other stat meds that if they put them in stat or if there are certain categories of meds, like, yes, the patient needs it now. But I'd like to kind of look at ways for our system to to be able to kind of default to giving nurses, giving pharmacy the time to be able to administer these meds that are not time critical. So,
do you see any barriers with like possibly policies that might need to be approved for that?
Certainly. I mean, I think one of the biggest barriers is actually technological. So right now in our system, we don't know of a way to flag certain meds differently for in terms of the time that gets placed on them. So we can't differentiate, say, antibiotics from, routine blood pressure medications or something like that. So if we turn on the setting that all meds get pushed out 2 hours, then it'll be the responsibility of the provider / pharmacist to remember that, antibiotics have this auto 2 hour thing. I need to pull that back and make that 30 minutes. And we can see people just missing that sometimes. And so that's really the biggest barrier in terms of getting everyone on the same page on what a reasonable turnaround time is. I think we kind of looked at it, and most people have, kind of turnaround time documents for, what's the turnaround time for stat meds and what's the turnaround time for routine meds. And we kind of looked at that. Most people are around like at the hour mark for routine meds, but that's something that, I think if we got a good push around it and it was a system initiative, we could get it through everyone's P&T, because that's what we currently do now. The system makes a lot of decisions that kind of have to go through local P&Ts afterwards. So,
okay, that sounds good. Yeah, that sounds like a really interesting project.
Yeah, hopefully, we'll see. It's the technological issue is what's holding it back now. I think kind of looking and hoping for some future development that would allow us to differentiate maybe drug classes, specific drugs that we could target for, getting automatically put out 30 minutes and everything else gets put out 2 hours. And then I think that being an automated process would allow, I think, just general hospital workflows to go much, much better. Right. Much more lead time for everyone to be able to accomplish their work and in ways that doesn't affect patient care. Right. I think it would be tremendously helpful for just smoothing out the operations of the hospital and preventing pharmacy calls, which I think are the bane of every pharmacy. A bunch of calls. Yes.
So do you have any advice for any, current pharmacists or maybe pharmacy students who want to get into the informatics and technology side of pharmacy?
My advice would be there's typically two ways of doing it, at least historically. Either you're kind of working in a particular institution that ends up going live with a new system and you kind of get pulled into it there. And that's been historically the way that pharmacists have been pulled into informatics, or to do a residency. I think that the opportunities to get pulled in because of go lives are, if I'm just kind of thinking about how I think about the landscape, I think those are kind of going away a little bit, just because, a lot of places have recently switched, to a new EHR. And so I've kind of settled into one that they're looking to use long term. So that being said, I think the best opportunity is to do a residency, PGY1 and then a PGY2 informatics residency. Maybe one of the easier ways to get that experience. But I think there could still be opportunities to really, get some really good work experience and to really, I think, familiarize yourself with operations, because I think that's really huge in terms of informatics, being able to understand operations, clinical, and just the workflow in the pharmacy, to be able to provide value, and then to maybe try to get an IT certificate and kind of go from there and see if you can kind of network and play the field a little bit. But yeah, a residency would be the most straightforward route.
All right. Thank you for that advice. That was really good advice. So to be respectful of your time, I'd like to thank you again for taking some time out of your busy day to be on the show.
Thanks, Tony. Thanks for having me.
Yeah, of course. If you guys like this episode, you guys can subscribe and rate us on iTunes, Stitcher, Google Play, Spotify, or any of your other favorite podcasting services. And you can follow us on social media on Twitter or Facebook at PharmacyITme, our Instagram at Pharmacy Informatics, or email by pharmacyitme@gmail.com. You can also follow me on my personal Twitter account at TonyDowPharmD, and our website is pharmacyitme.com, where you'll find occasional updates and blog posts. Thank you again for listening, and I'll see you on the next episode of Pharmacy IT and Me. And remember, technology is the tool, patient care is the goal.